Good afternoon. This is the section to discuss pandemic, the Corona-19 pandemic and the application of the AI to flatten this pandemic crisis. So this afternoon I have two speakers, Professor Park Tae-sung from Seoul National University, and also another speaker from the Sungkyunkwan University, Professor Baek Young-nan, and we have also discussant online, Professor Jong-hwa Park, and then he's going to join from the Ulsan UNIST. That's what we call in Korea. So I'll speak with some, I think, the introductory remarks, and followed by this presentation. And then Dr. Jong-hwa Park will be joining us as a discussant. And then we'll have some Q&A together among four of us. So I'd like to welcome all of you joining us by online. And we don't have any audience because of this pandemic. And then we have this recent surge in Korea, especially in capital Seoul area. So we decided just to go ahead without the audience, but we are very happy to have all of you joining the online. So let me briefly say a few words for this particular section as part of this Global Korea Convention 2020 that we started this morning. Instead of, I think, some remarks that I prepared, let me kind of put this in context of today's Global Korea Convention. This morning, we shared the so-called vision statement for the 2020 Global Korea Convention toward a world-leading nation contributing to world peace, co-prosperity, and sustainable development. And let me just, I think, to repeat a few words, the remarks that may be very suitable to our discussion. This vision statement begins with the following introduction. Quote, with the outbreak of the COVID-19 pandemic, the global community is facing an unprecedented threat. The virus is spreading with no end in sight, while the economic crisis is accelerating. Inequality is expanding both between and within countries. And so we have presented five sort of objectives to accomplish this vision. And one of those, I would say, I would point to actually the third sort of goal that we decide to share with people in Korea and abroad. And it says, the third goal that we would like to share here is that we shall strengthen international cooperation and an alliance to expand global public good in the post-COVID-19 era. In particular, international cooperation should be promoted so that COVID-19 vaccine, a global good, can be used fairly by all. Furthermore, we must pursue reforms in global governance to reduce inequality in healthcare and work to enable shared prosperity. All stakeholders, such as governments, non-governmental organizations, and civil societies, must all collaborate in creating an international order of mutual and common prosperity so that the global public good is sufficiently well shared among all of us. I think this is actually saying pretty well what the context is as we talk about this pandemic crisis with the application of the science that we can apply to this particular the surge. And let me kind of show you a few things as part of my remarks. And I think the two speakers will make their own presentation, but I'll just personally share some of the challenges and opportunities that we have actually grabbed in the past 9 months since this pandemic, I think, hit everyone on this earth. And I would say how we can nurture science tools and remain adapting to this new normal we all are facing. As you all know, I think everyone across this planet is struggling with this COVID-19. So I think some of the key authors have come up with this performance index for OECD countries in the most part of, I think, this year, as we all go through this crisis. And this particular index is constructed based on, I think, a few global health security indexes and some other, I think, the critical measures, including reproduction rate and number of the death, and then other, I think, the health-related measures. And as you can see, especially when you see it, when you listen to this by online, you can see, well, ROK, South Korea, is actually among the top when it comes to this global health security index. By the way, this is constructed by, I think, this Sustainable Development Network Solution, the research group based in Columbia, in New York. And there are many other countries in this top 10, I think, the countries that have done pretty well in terms of the health security. And it's not surprising, actually, Korea has actually got that spot among other, I think, leading countries. But you may be surprised, there are not many Western countries in the top 10. US, UK, and then many other OECD countries are not necessarily in these top 10 countries. And this, I think, very well, I think, speaks of how well Korea has done in comparison to other countries we call, I think, the developed countries. So I'd like to just say a few things that we have done well in the past 9 months. First, Korea has done pretty well in terms of smart testing and tracing the patient or tracing those people who are infected and treating people in isolation to flatten the pandemic curve and sustain economic activities. I think my observation so far is that Korea has prepared pretty good legal infrastructure since Korea has gone through this the MERS outbreak back in 2015. So we actually had sort of this collective, I think, the good or the public good ahead of the individual gains. So this legal infra has been very important as we make some important, I think, the government decision for the public to actually respond to. And a couple of other things that we have done and then practiced in the past 9 months is that we try to have some newscasting based on the data. And third, we try to have some scientific interventions together with international science community. So we learn what are the good practices and best practices to control and harness this COVID-19 pandemic. This is actually, that particular law that we have actually institutionalized back in 2015 in response to MERS outbreak. And then we had some, I think, the smart quarantine info system institutionalized back in 2017. And then this year, we have used some big data system for precision tracing. And also, we could share some location data with the public evolutionarily, so we can have some, I think, the higher level of privacy over the time. The thing in the box is that actually the law that we have already institutionalized back in 2015 to have, a sort of very good legal structure in place so we can respond well in case of the crisis coming up. And that's what we have actually gone through this year. Let me show you just a couple of slides before I wrap up. So this is one example of how we used big data to see how people are moving from place to place. This is based on the SK Telecom mobile big data, about 30 million people, and we extrapolated. So we can see how people are moving based on their mobile phone location. This is the latest, actually, visual, I think, the visualized data of the mobile phone location. So in this case, we have actually traced all this mobility on the weekly basis since January 2020 up to, I think, this month. So now, what I can tell you here is that we have actually seen 18% of decrease in population movement after the latest surge. This is actually very important, I think, the data we can use, whether people are responding properly in response to the latest, I think, actually the upgrade of the social distancing measure, I think, demanded by the government. So here, another thing you can kind of observe is that mobility level is actually getting very close to the lowest level in the third epidemic wave of the, I think, we experienced back in August and then September. So we are going in the right direction, as you can see this data. And this is another thing that we keep, I think, keep watching. So how people are behaving in terms of mask wearing practice. And this is the pattern that we see in many other countries, and other countries actually following suit. So even a few countries that have not done it in the beginning of this crisis, they are doing pretty well, and they are using the mask pretty well, except a couple of countries like Sweden and then Denmark. So this is the example of the some model-based neocasting that we have done since last March. So Korean academics and then private sectors have been working together to use some SIR model-based, I think, the prediction, and plus some variants of the SIR model. So we can come up with pretty good, I think, predictions in the near future of the this COVID-19 behavior. Just some, I think, the principle or methodology behind it is that when we actually do some prevention, actually we have, I think, some level of infected people at a certain level always. So this is very strange, but the more you've done, the better you've done a good job of the prevention. Actually, you have a lot of people are still remaining. So we have to continue working to control this COVID-19 pandemic. But one good actually insight that we can learn from here is that as long as we control it pretty well in terms of the impact of this pandemic and certain level of actual intervention, we can do so-called dynamic distancing. So as you see in this graph, there's a sort of some, I think, the small wave-like movements. And that is the sort of effect of dynamic distancing. What do I mean by that? As long as we can control this pandemic pretty well with certain the social distancing measure and then other restrictions, we can control it, and we can have some level of economic activities. And so we cannot actually go over certain threshold that public health can actually contain. And that is shown by that dotted line between that low wave-like lines and then this high the wave. So as long as you do not hit that threshold, the public health, the threshold, we may be fine. And that's what we have done well in the past 3 waves. But currently, as we go through the 4th wave of the recent surge, we are actually passing through that public health, the threshold we try to maintain. So we have to see how well we are going to do. I'm going to skip some of these slides, I think, as a demonstration of how we have done this kind of prediction modeling. So I think what I like to say in closing, we need the seers to do some good neocasting to predict pandemic curve. We need some, I think, the evidence-based practitioners. So we can come up with some good non-pharmaceutical interventions in balance with economic and social revitalization. Lastly, we need precision scientists who can actually use AI and then science to actually do some prediction and also have some good treatment of the patients. And that is actually topic of today's discussion. And so I'm going to stop here, and then I'm going to move on to the first speaker, Professor Park Tae-sung from Seoul National University. Oh, I'm sorry. The first speaker is the Professor Baek Young-nan from Sungkyunkwan University.
Good afternoon, ladies and gentlemen. It's my pleasure to have an opportunity to give a talk at this Global Korea Convention 2020. I'm a clinician. I'm an infectious disease doctor from Samsung Medical Center, 성균관 University School of Medicine. 강의 시작할게요.
So I'm going to start my talk.
Characteristics and the outcomes of COVID-19. I will focus on the data from the Korean studies. I'll briefly talk the current status of COVID-19 and followed by the clinical characteristics, complications, and outcomes. Up to now, globally, about 67 million are infected, and among them, 1.5 million are dead because of COVID-19, and the case fatality rate is 2.3% globally. As you know, we are facing the third wave of COVID-19 in Korea, and as you see the left figures, the number of cases are steeply increasing, and we are not sure how big and how long it will persist. I think it will depend on the compliance of practicing social distancing by the people. These figures the COVID-19 status in Korea by regions. Daegu is the first epicenter of the first outbreak in Korea. As of November 20th, the number of cases in Seoul exceeds the number of Daegu. These figures are the COVID-19 cases by ages. The most common age group is young adults globally. It is almost similar in Korea and other countries. The right figures is from the United States, and compared to the United States, there are more persons infected among in their ages of 50s and 60s. In Korea, actually the elderly persons are a high risk group for the poor outcomes. Incubation period means the interval between the infection and the development of clinical manifestations. The incubation period of COVID-19 is known as average 5 to 6 days, and as long as 14 days after infection. And usually the infectious diseases can be transmitted after the development of clinical manifestation. In contrast, this COVID-19 can transmit the disease before the development of infection, usually 1 or 2 days before the development of infection, and it was the main problem of failing to contain the COVID-19 in the early phase of the pandemic period. This figure shows the clinical courses of COVID-19. As you see the bottom of the figures, most patients are experiencing the mild or moderate illness. Usually it improves within 10 or 14 days. And some part of patients are progressing to pneumonia in 5 or 10 days and getting worse to the critical release in 10 to 14 days. This blue line shows the amount of viral excretion. This virus is excreted in the early phase of the clinical courses. So it means the COVID-19 usually transmitted in the very early phase of infections with the very mild symptoms. Fever, dry cough, and fatigue are the common symptoms of COVID-19. And the other symptoms include headache and some other respiratory symptoms, including nasal congestion, sore throat, coughing, sputum, dyspnea. And the general symptom is myalgia, arthralgia, chills, and gastrointestinal symptoms, including nausea, vomiting, diarrhea. And severe cases can have a higher fever than the mild cases. A study from Korea evaluated the clinical course and outcomes of 3,000 patients, accounts for 26.6% of total patients at that point. They divide the patients into mild, moderate, severe group by the severity scoring. Most of the mild patients on admission, about 5% were moderate and 2% were severe cases at the time of admission. The common symptoms were fever overall, and followed by sputum and myalgia like that. And in severe cases, have more fever and sputum and myalgia, dyspnea, and altered mental status like that. Among the studies, about 32% had pneumonia, depends on the severity. Severe patients has bilateral pneumonia more likely. During the admission, the patients aggravated the severity. Among the mild cases, 2.2%, and moderate cases, about 9% aggravated to the next stage at the time of 14 days after symptom onset. And day 28 mortality rate was about 7.7% among moderate cases and 22% in severe cases. So, but there was no mortality case among the mild cases at day 28. Acute loss of smell and loss of taste was commonly found. In the study from Daegu, evaluate the prevalence of acute loss and smell or taste. About 15% had anosmia or agusia by the evaluation. And about 7 days, the median patients were improved their symptoms, and for 2 weeks or 3 weeks, the symptom was almost gone. In the study, they divide the patients by severity. As a whole, the mild cases was most common, about 83%, and 12% were classified by moderate, and 4% were severe or critical. This classification is basic data for the modeling, so I show you this data. Laboratory abnormalities are lymphopenia and elevated aminotransaminase and elevated lactate dehydrogenase level. Also, the inflammatory markers are elevated, and some coagulation tests have the abnormal findings also. As I told you earlier, pneumonia was found usually about 30% of cases, and the chest X-ray can miss the pneumonia finding in the early cases or mild cases. So chest CT is more sensitive to detect the pneumonia compared to chest X-ray. The right figure shows the very typical finding of pneumonia on chest CT. Some patients have the clinical complication. The respiratory distress syndrome is the most common. Also the renal failure, cardiac failure, cardiac arrhythmia, and some thromboembolic complication, including pulmonary embolism and acute stroke, can occur in the severe cases. Case fatality rate is high among the elderly patients. So it is about 20% in ages of over 80 and 7.1% in 70s and 1.25% in 60s. And the case fatality rates are lower in younger groups. We evaluated the risk factors for the mortality or respiratory support. The higher CRP level above than 8.0 milligram per deciliter at the time of admission was strongly associated with the respiratory failure or mortality. A study based on the Korean National Health Insurance big data evaluated the correlation of comorbidity and the mortality in patients with COVID-19. The study shows the diabetes mellitus and heart failure and renal failure were highly associated with mortality. In summary, Korea is the third wave of the COVID-19 outbreak, and containment is difficult because of asymptomatic or pre-symptomatic transmission. And the incubation period of COVID-19 is average 5 to 6 days. Usually symptom improves after 1 to 2 weeks in the most of patients, but the part of patients experiences progression to pneumonia within 5 days and respiratory failure within 10 days. Mortality rates are increasing with the age, 20% in over 80 years. So I'm going to start my lecture wishing you stay home safely. Thank you.
Thank you, Professor Beck. I think this is helping us to put things in context. So the next speaker, Professor Tae-Sung Park, will talk more about this prediction of the COVID-19 patients based on some, I think, the important correlates and using the machine learning, I think, the approach. So, Professor Park, your time.
Okay, 시작할게요. Thank you for Dr. John for giving me this nice opportunity to present my work here. And the title of my talk is Machine Learning-Based Prognosis, Prediction of COVID-19 Patient. So I will give a brief introduction, and then I will introduce our data set, and then I will introduce what we have done so far, including 5 different specific aims. And then some final concluding remarks will be followed. Okay, I think Dr. Kyungnan Baek showed this kind of pictures already. Okay, so the left one is the daily confirmed cases globally. And the right one is the one in Korea, and we are actually finished the second wave and we are moving to the third wave. I think the top on the right graph is about 600. Now we are very close to reaching the 700 today, actually. And these are the daily deaths all over the world, is the left graph. And right graph is the daily deaths in Korea. And actually, it is the 7 days average, and we are reaching around 3 deaths per day right now. And this is the graph, COVID-19 trend worldwide. How long does it take for COVID-19 to stop? I think the same numbers were presented by Dr. Beck. And our current confirmed case is about 67 million. And now we have over 1.5 million deaths. As you can see, we have all the red ones all over the world, right? Especially in North America and also Europe is getting serious, and also India is getting serious. And also we are actually suffering like in the cold weather. The winter COVID surge is the worst event that this country will face. White House Health Advisor Brooks said. Okay, I think some of you may have seen this kind of pictures. This was actually happened in this April. The picture is from India, and also we got some problems in Japan and also in Europe, right? And also a similar problem happened in Korea, in Daegu, when we first encountered these ones. But a lot of specialists focus about concerns about this kind of COVID-19 situation will be very long. So we have to prepare for the explosion and the reunification. But actually it happened. Now we have about over 600, 700 new confirmed cases, right? Okay, what kind of this kind of rapid increase in confirmed case causes? Okay, what kind of problems can be broken here? So this is the well-known story, this confession from one of the atheist doctor from Lombardy in India. At first, a few people were brought to hospital, then a few dozens, then a few hundred. Now we are no longer doctors. We are just ones sorting labels, deciding who can live and who should be sent back to home to meet death. Even if they have been faithfully paying taxes for the country for their entire life, they are sent home to prepare for death. Now we can confess, as human beings, we have reached the limit where we can no longer do anything in this situation where thousands of people die every day. I realize my uselessness on this earth now, but I want to give my last breath to help others. I just found this picture yesterday, but I think there have been some debate about this is real or not. I mean, his name is good, right or not. But when I first read this kind of article, I was very touched. Okay, and then I think about what would be the clinical characteristics for this COVID-19 patient. So when I first started this kind of problems in early spring, there are several challenges in dealing with COVID-19 patient. Like, for example, sudden worsening of COVID-19 patient with very mild symptoms, but it's very unpredictable. And there are a lot of asymptomatic patients, right? And so far, I think, as you know, there's not many active treatment, only one approved treatment, remdesivir, but it's not as much effective as what actually expected. And the vaccine is coming, only one in UK is approved, but I think a few will come soon. And also there are many cases for reinfection of the COVID-19 virus. And also there are a lot of side effects, after effect is getting serious these days. These are very challenging issues. It's quite different from the other infectious disease, right? And at the spring, after receiving this kind of news, we think about what our lab can do for fighting with COVID-19. So it's kind of very challenging problems. So I like to contribute something with my students. So this is what our group have worked so far, last 20 years actually, when I first started looking at some micro data. So our group have developed many different statistical methods and models for working on precision medicine. So the left is the very different kinds of data set. For example, we are dealing with clinical data from the patient, and also we are generating a lot of genomic and transcriptomic data, and recently we are working on a lot of microbiome and metabolomics data. Our main goal for applying like the statistical model and also deep learning AI-based model is to provide some useful tool and prediction results for the clinical application. For example, we like to do something about to make predictions for drug response, and also we like to make some prediction about the prognostic, and also we like to do something about the recurrence prediction, and also we like to do something about early diagnostics, right? So what we can do from the left side to the right side to the real clinical application. So our group have worked a lot for choosing some markers of interest, because the left side is high-dimensional data, and we need to select some predictors to make some predictions. And for the chosen markers, we have built several models based on statistical models and machine learning-based models, right? So that's what we can do because we have worked on this part for 20 years. And so I will give you just one example. Our group has working with some like the pancreatic cancer data set. And here the intraductal papillary mucinous neoplasm, we call IPMN, is the early stage of pancreatic cancer. It can be like malignant or not. So before making any resectory, it's very difficult to decide whether it's going to be cancer or not, right? So we had a chance to work with the medical doctor working on this area. And we identified some markers of importance, like the age and some certain marker values. And then we developed this kind of prediction models, and we make the software available. It can be easily run on our web site. So each values represent important markers, and each bar shows how much that each predict can contribute the overall estimation of the probabilities, whether it is malignant or not. So this kind of model would be very popular, and I just found out that we upload this nomogram in July 2018. It's been a while, for more than 2 years. And last week I found out that like as of December 1st this year, more than 70,000 users from 62 different countries, right? As you can see, a lot of users from the Korea and Japan and like China, and also a lot of users from the North America and Europe, right? So I didn't know that this kind of number has been so popular in this pancreas studies. So I was very proud of it, and I like to do something, similar things for the COVID-19 situations, right? So in this spring, we thought about how we can do for COVID-19. So we prepared this kind of diagrams. The left part is the data set from the COVID-19, right? So for each COVID-19 patient, we got some initial symptoms, and also we got some epidemiological information. And while he's hospitalized, while he's being treated, we continually collect some clinical information, right? So those are going to be our input, right? And then from those data set, we can select some markers of interest, and then we can build prediction models. So what we can do using those models, so after discussing with some infectious disease medical doctors, we decided to work with the maximal clinical severity score, and how long this patient gonna last in hospital, for example. And then third is clinical severity score pattern and drug response, and asymptomatic and patient illness kind of things. So for this COVID-19 project, our final goal would be prognostic analysis of clinical data from COVID-19 patient, and our specific aims are follows, 1, 2, 3, 4, 5. So I'd like to go through one by one. We are lucky to have a chance to work with some COVID-19 data set. The first data set what we have worked with is from Korea Disease Control and Prevention Agency, KDCA, right? And this data set, we were able to analyze about 3,000 patients. And the last follow-up date was May 29th. And we started looking at this data set from the middle of April. And because some restrictions, we have to visit there with my students to analyze this data set. And fortunately, we have a grant from KDCA to make this analysis. And also the Korea KDCA made some public data available for the researchers. So about second day is about total of 5,000 patients. Okay, and the last follow-up date was April 30, 2020. And we were only allowed to make analysis for 2 weeks actually. And then we asked to 1 more week. So we had to finish this analysis for only the 3 weeks. And we were very quick to make analysis, and we prepared 1 draft, and it's under review right now. And while working with the first data set, we had a chance to work with the Professor Shin-woo Kim. He's also the infection disease specialist. He played a very important role in Daegu situation. And he greatly shared his data set about 200 patients collected from Daegu hospitals, and we will analyze this data set, okay? But unfortunately, the first data set is not allowed to make any presentation or publish any results. So in this talk, I will focus about 2 data sets, KDCA public data and Daegu data set, okay? So in this data set, we have some initial variables like height and weight, and some demographic, and some clinical findings at admission, and some comorbidities. And also we do have some daily data sets available. While they're in the hospital, some measures are continually obtained, right? So we have some clinical severity scores there, and also some lab tests are available for these 2 data sets, okay? So these are the structure of data set. And these are simple comparisons. When I prepared the slides, we freeze the data like May 12th. So KDCA represent, the last one is about 3,600 patients, the total Korean COVID-19 patient. And the pink one is about public data, and the sky one is the Daegu data set, right? So left table shows the overall frequency. So it looks some different. But if you look at its proportions in terms of the age, so they are still very similar, but except that only Daegu data has some older people, right? And this is the gender distributions for the male and female, right? If you look at the proportion, they look very similar, and especially we have more data for the female patient, right? And let's look at specific aims one by one. The first one is the maximum clinical severity score predictions. And for this analysis, we use 2 data sets, KDCA public data and Daegu city data. Okay, what is our goal? Our goal is to develop models for predicting maximum clinical severity, and we call it MaxCSS, based on initial and some epidemiological data from COVID-19 patients. So what does the maximum clinical severity means? Okay, for example, one patient entered this hospital. His condition was mild, but he moved to moderate and then severe, and he became very critical, or become mild again, right? So he goes through many different CSS levels. But when we say the maximum CS, it means the one with the worst CSS values, right? So each patient has only one max CSS values, right? Okay, this kind of analysis has been done by many researchers, for example, some Korean researchers used this kind of analysis already with a small data set. And when you look at their outcomes, they focus about the severe status like ARDS or the ICU admissions, or death kind of things. So they focus about the binary outcomes. And I've found that there are many publications using the Korean data set, and also the military doctor, Dr. Ho, I think, published some papers about using the similar type of data set, and he based on the models. So the pink one represents the models. Most paper has been published using the logistic regression. My second paper, XGBoost, is based on deep learning models, right? When we first received this data set, the KDCA provide 8 different CSS levels, right? 1 is the most mild one, no limit of activity. 2 is the limit of activity, but no oxygen therapy. 3 and 4 is the O2 with no nasal prong, so it's a very light oxygen supply. And 5, 6, 7 is like very strong, like ventilation kind of therapy, and also including ECMO and death, right? So as you can imagine, like handling 8 different levels would be very challenging. So we collapsed those levels into 4, with mild, moderate, and severe, and critical. Okay, so for the mild part, we used no limit activity for KDCA, and moderate means limit of activity but no oxygen therapy, and severe is light oxygen therapy, and critical is high flow oxygen therapy, right? But when we're working with Dr. Shinho Kim at Gyeongbuk National University, he suggests using some temperature information. So we use a little bit different mild, moderate definition, including temperature data set, right? Okay, so this is the distribution of our data set. For example, KDCA, mild is about 4,400, so about 80%. Moderate is about 6%. Severe is 9%, and critical is 5%. But when we use the temperature information, then, for example, in Daewoo data set, we'd have about 30% mild and 40% moderate. Okay, and severe and critical is a little bit different, right? So a lot of people from the mild tend to move to the moderate groups when we use the temperature information, right? For this 4-level data set, we tried some simple analysis. That's why we just combined them. The first analysis, we look at the mild versus others. Second is we combine mild and moderate as one group, and then above severe as one other group, right? And 3 models, we focus on critical, and all the others remain in one group, right? So we consider 3 different models, right? And the model, what we considered is that like we tried logistic regression model, like in terms of the success probability, we have the S-shaped graph. And then we can try the random forest is based on the tree-based models. And by generating some bootstrap data set and also aggregating some voting, they provide some well-improved prediction results. And also, as you can see, a support vector motion is a very well-known classifier. For example, if we want to combine the red and the green ones, then we can define some hyperplane, right? And deep neural network and guide is a new one, what we actually tried. So as you can see, we tried the deep neural network for this data set. It contains like our input and output, right? Our input data would be some clinical information from the early stage of the COVID-19 patient, and outcome will be some classification. Like we can use 4-level classification, or we can use 2-level classification, but we can put many different layers, to improve the prediction performance. And also the guide was actually proposed by Professor Wei-In Lo. Actually, he contacted me to work with our Korean data set in March, right? But it takes some time to get their data set. So after getting some Korean data set, when I contacted him again, so he's not interested in our data set anymore because he had a lot of 50,000 American people, like he's working on that data set analysis, right? But I think his model, like called it like a guide, is very useful. It provides very intuitive interpretation of the result. Okay, so we tried these ones together. Okay, the first analysis was about, we look at just univariate analysis by focusing about one variable by one. And our outcome is max CSS with 4 levels. As you can see here, the age and body temperature and BMI, heart rate, and SPP, like the positive related risk factors. And also male has a chance to have higher CSS levels. And also like some comorbidity variables like diabetes and hypertension and so forth. So those are very well-known risk factors. And for this data set, we perform like a very detailed statistical analysis, but they provide consistent results. And also for Daegu data set, we did the same analysis. So we identify some risk factors using initial vital signs and clinical findings and some other comorbidities. And also some patients have some X-rays on the CTs. Those are also very informative. And like these ones. Like for example, if we look at some simple draw for each age like x-axis and y-CS values, and you can see this kind of linear increasing patterns, and it can be found in our data set. And also, if you look at the sex, male tends to have, female tends to have the more severe CSS values. And also, for example, when we look at the shortness of dress, then you can have this kind of symptoms, then it has high chance of having the high CSS values and so forth. So each value can be interpreted similarly, even like, for example, diabetes. If you look at the right side is yes, left side is no, right? If you look at right side, yes, then he has more chance to have high CSS values and so forth. So this kind of graph can be easily interpretable. And when we look at this data together, we got 21 commonly identified from 2 data sets. So those are very informative risk factors in our analysis. And then using all data sets available, we built some prediction models in using multiple models here. So we applied logistic regression, and also we applied random forest and support vector machines, and also we applied DNN, deep learning models, right? The last column shows AUC values, and as you can see here, when we use the Daegu data set, our AUC value is like 0.935, right? That's the highest AUC values I have ever looked all the other literatures. So it provides very good predicted results. And when we compare the mild and moderate versus severe and critical, we got some performance, but its prediction is a little bit lower. And also when we compare the others and critical, it also very good predicted values. Like for example, KDCA public data set, we do have like AUC 0.944, right? Very good predicted, well predicted result, right? And this is the guide result. But this performance was not that good, but it provides very intuitive result here. And based on this data set, we built nomogram for, this is the, for KDCA public data set, okay? So if you put some numbers for each selected markers, so it's moving right now. And we have 3 models. We can choose one model. Oops, and then, oops. Okay. And then you got the results. It's very fancy results. It's on our web page right now, so you can use it if you want. Second topic is about clinical severity score patterns, right? For example, one patient goes mild, moderate, is okay. Second patient goes mild, severe, and mild. Third patient goes to moderate and critical and moderate, right? So we are interested in looking at some trajectory of each patient, right, based on CSS. And then we are interested in looking at some predictions. If one patient came is like the positive results, then what would be his like trajectory for CSS, right? So that was our analysis. We look at some Daegu data set, and we identify some patterns. And we also identify some risk factors, and we make some prediction values here, right? But in this case, we especially focus on about those who have only the mild symptoms. So based on these ones, we also finished program, and it's on our web page right now. Okay, so this is also movie. Okay, but if you look at the bottom, there is our web page site. You can look at it. Okay, it's very slow. Okay. Now our third topic is the treatment period time, right? Do you remember that how many days the Daegu patient 37 stayed in hospital? I was told that she stayed more than 120 days, right? But some other patients, famous patient like Pastor John, he stayed only 2 weeks, right? So it would be very interesting how long each patient going to stay in a hospital. So we look at those data set, and we just computed those treatment period or the staying period in the hospital. Like we used the Daegu and KDC public data set from the initial to release, right? So we used 2 different treatment period for 2 data set, and we built the same models based on KDCA public data and also the Daegu city data and based on the time, all right? And also we just compare those two results. And then what we did is that we just look at some binarized the data, long period and short period, right? And then also we do the same analysis using the logistic regression models, okay? And the first topic is drug effect analysis, right? And for our data set, we had a chance to look at the cholesterol and hydrochloroquine and steroid. And also we have some chance to look at the remdesivir for KCDC data. Okay. And while looking at this data set, we found that there are some differences in terms of each patient staying in the hospital, right? So some drug has the effect of reducing the treatment period, and some are not, right? So we just compare those two results. And also we developed some others, like for example, the column represent the before treatment and row represent before treatment and the column represent after treatment, right? So each patient started mild, then he become mild is 23. This mild become moderate, and mild become severe and critical and so forth, right? So diagonal numbers are unchanged, but on the upper diagonal part is the worst cases, and the lower diagonal numbers are the improved cases. So by comparing those numbers, we were able to compare the drugs. So we got some result here, and also we just compared before and after treatment scores. Okay, so this is the results. And finally, we're looking at the asymptomatic patient, right? But this data set, we look at the Daegu city data, and the total data is about 7,000. Among them, like 5,000 are from the residential treatment center. So they have only gender and age information, no clinical information, right? But we know that they are asymptomatic patients, so we just look at them. So data will be asymptomatic patient who have no symptoms in the residential treatment center, and we just compare them with the symptomatic patient, right? So this is, if you look at these ones, like this Kaplan-Meier plot, and they show some differences here. Like if you look at the median, the asymptomatic patient stays about 24 days, and symptomatic patient about 27 days, although there's not that much difference, but the difference is significant. And if you look at this age, it's very interesting, right? So the first line represents the age under 20. So if you look at those two numbers, 0.58, 0.42. So asymptomatic patient rate is about proportion of 40%. But 20s, it becomes 40%, 30s, 33%, right? As you can see here, as age gets older, proportion of asymptomatic patient reduce greatly, right? So you can see those kind of patterns. So that's actually what we observed in our city right now, right? And also if you look at the male and female, there are more proportion for asymptomatic patient in female. Okay, that's not what we actually expect, but it has happened from this data set, right? So I'd like to conclude my talk. So in this presentation, I just briefly go through 5 different specific aims using actually 2 data sets, but we also have the 1 data set from KDCA. Okay, so this is what we actually had so far. And hopefully, I hope this kind of work can be used in real clinical application for fighting with the COVID-19 patient. And we do have some progress about in scientific area, but I think our work hopefully contributes some like real practices. That's what I want. And when I look at this data set, I think our data set is a little bit old. Like the Daegu is August 30 is the last follow-up, and KDC is about April 30, so right, pretty old. And when we look at this data set, a lot of NAs in clinical data, and also there are some limited number of clinical variables, and also very challenging in some data integrations, right? So it reminds me some fundamental issues, right? The data should be updated. As you can imagine, the more data, the more accurate predictions, right? And also data quality is very important. As you may have heard about garbage in, garbage out, right? So the quality of the information coming out cannot be better than the quality of information that went in, right? So good quality of data would be very important. So first thing what we can do is some kind of data standardization to deal with COVID-19 patients. And we are dealing with the retrospective studies, right? So I think if we pay some more time and if we design well, then I think high quality of clinical data can be obtained by designing some follow-up kind of studies, right? And also, I think it was very important issues for effects of COVID-19. So this kind of design would be very important. And I think this kind of thing can be done by government, right? So I think the standardized protocol for COVID-19 would be very important. Okay, so this has been done with my some statistical groups and also some clinical team, Dr. Kim and Dr. Oh and Dr. Moon, okay? And also I worked with Dr. John here. And I'd like to thank all my students who worked for COVID-19 clinical team. They worked very hard. They worked very voluntarily. And also our group has worked on some modeling team. Some of the results has been shown by Dr. John. Okay, so this is one part that we are working right now for modeling. And also, I think Dr. Jong-hwa Park will talk about some SNP data, and he's very interested in generating the SNP data, and also I'm very interested in looking at this data set, and our group is working on some biobank SNP data for COVID-19 patients. Okay, I will stop here. Thank you.
Okay, thank you, Professor Park. I think I gave him more time than planned, because we have this worldwide online audience. This may be the first time that he shared this important AI-based, I think the COVID-19, I think the research. So hopefully more people can listen to this afterwards. So let's turn to our discussant, Dr. Jong-hwa Park with UNIST. Dr. Park, will you join us to share your discussion points? You have 20 minutes. Oh, I'm sorry, you have 15 minutes.
Thank you very much. Actually, so today this is about prediction, the prediction of the future and possibly future pandemic disasters. So I'd like to cover some social aspects and technical aspects, and finally, how government institutes can cope with this kind of thing. So first, I think this coronavirus is the situation we have is mostly human disaster. I think that's something we need to remember, because a lot of collaborative networks or systems in the past have been kind of broken down before this pandemic. And that's why there was actually lack of communication among scientists who could check the original data and how we can cope with all this viral infection and so on. Anyway, so it was a human disaster and it expanded really rapidly. And some countries, managed to cope with this. Some other countries failed miserably, and unfortunately, a lot of people died for that. So the answer or the core of the problem started as human disaster. That, in my opinion, the most important aspect of dealing with this properly was science and technology. So some countries relied on data, predictions, computer algorithms, simulations, and so on and so forth. And while some other countries actually believed in their, in a way, confidence, faith, they had a belief system on how they can cope with this kind of thing. So there was a huge, forking point where science was used widely, and some of the, countries it was not the case. And underneath of this science and technology, in my opinion, the most important aspect is democracy. The government, the society, and each citizen contributed to the level of democracy in practicing this democracy in terms of communication and how actually we collaborate to each other. So the social distancing was mostly successful in Asian countries where people conformed to the idea of public safety. So I think that was very important. And Korea was a model case where people, the public, responded really well. And unfortunately, still we had three instances, three big waves of this virus. The cause, unfortunately, was totally social and mostly done by sabotage of the people who actually didn't conform to the constitution, the social rules, and they actually actively sabotaged in certain cases. In August 15th, these certain religious groups really actively went against the policies and the social well-being, and that was a disaster. And that actually lingers on in such a way that the third wave is firmly standing on the second wave, spread all across the country. Very unfortunate, helped by the weather, climate. And to deal with this thing, we need more than coronavirus kits, PCR kits, and some tools. We need social infrastructure accompanied by or helped by science and technology tools. So there are two things. So the future relies on, in my opinion, heavily on these two things. One is government infrastructure, where they can force with power, the power given by the public, on how to manage certain groups of people or certain sectors of society, people who go against this kind of scientific paradigms, where they actually refuse to wear masks, where they refuse to avoid a meeting or gathering together for certain purposes, whether it is business or religion or whatever. And that can be enforced, in my opinion, or we can persuade the people only using scientific data helped by statistics. So in that sense, Korea's success so far suppressing the pandemic is based on a lot of people's data, as two presenters presented here on the data and how they actually presented very openly, transparently to the public. And then they made the predictions. And this really helped the government, the top government officials. And again, this was followed by, in my opinion, very diligently by the medics, the people who actually confront the situation locally, who help the patients, who manage the protocols, from the airport to their homes and so on. And a lot of these procedures, complicated protocols, were assisted by technologies, IT technology, mobile phones, computers, all this GPS on these things. And government actively used those things. Anyway, so the core of the problem was a human disaster, mismanagement, and solving the problem was mostly from rational democratic decision-making and scientific infrastructure. Now, let's move on to the future. Now, we are confronting a situation where we have to release vaccines to inoculate people as many as possible, as in United Kingdom. And what kind of scientific data do we need? First, a lot of cases, the mistakes we made all across the world was based on false data. So, for example, people talked about the effectiveness of mask, which is ridiculous as a scientist. How can you actually even deny, this physical tool, in front of, right in front of your mouth, actually preventing this airflow? I mean, absurd. And there was argument going on early this year. I couldn't believe, some medical experts talking about the effectiveness of this kind of thing. And again, this happens, in my opinion, even right now. Early this year, people talked about the effectiveness of the vaccines or the danger of vaccines. I was really appalled to hear those. Vaccines, you think about vaccines is not even a drug, a cancer drug, or it's not even a treatment. It's just a vaccine, which is just a piece of viral, particles. And we actually, normally every day we inhale those tons of viruses, bacteria every day. Those are kind of potential vaccines. And a lot of people are afraid of actually approving this. And funny thing was the most less democratic countries such as China and Russia, supposedly, those people were ahead on this kind of thing. So I'm not saying we have to be we have to rush to take those things, but what I find it unfortunate was there was no playground or ground where experts and the policymakers and scientists gather together to talk about these facts. What are the facts? What are the scientific infrastructure? What are the principles here? And I didn't see those, even in Korea, unfortunately. But we were fortunate. Another thing is, Professor Park and Professor Peck talked about the data and predictions and so on and so forth. And as a data scientist myself, I was very frustrated, even now, by the lack of communication among the government, the database and the analysts, and the hospital who collect those data. In Korea, it's quite hard to get those data. I don't know how Professor Park managed to get thousands of those data, but I tried to get those. It was very hard. I managed to get certain samples in the early stage, and then it was really hard. And I contacted Ulsan City, where I live, and it was really hard to get those data, not only because lack of this communication, but it's a miscommunication as well. So a lot of these people who got infected were afraid of cooperating with the government and the city officials and so on and so forth. They were essentially they were the victims, but at the same time, there was a social stigma as well. And that was very sad because those people can help, finding solutions efficiently. So although we had this, really good group of expert group of bioinformaticians, statisticians, and scientists, we couldn't use all the data generated, collected by the government hospitals effectively. So, as you know, in UK, that was very efficient. They, had this consortium, and then they started to sequence really fast early. They are sequencing a lot of the people who got infection now, and I think next year we'll have very interesting scientific results from those groups in the UK. Anyway, another thing is, after all this, so Professor Bach presented his algorithms using neural nets, random forest, all these prediction methods. I'm sure he used Bayes, all kinds of interesting and advanced algorithms. What I suggest is the government, CDC, Korean CDC, needs to accommodate all these programs and expertise results and put them into public resource in the future. So we have to make a systematic infrastructure pipelines in CDC, Korean CDC, in a way that whenever we have this influenza or coronavirus or even an unknown new pandemic, we should have a very organized system of collecting the data, sharing the data, and automating the analysis in such a way that the government officials, high-ranking officials, can get the predictions really fast. So Dr. John, the head of the Korean Statistics Institute, Dr. John Young here, who is the host of this show, the session, he has been actually delivering almost manually. So he has been coordinating with a lot of professors and some researchers in Korea, asking this data, that data, prediction models using these Canadian experts and so on. So in a way, he was kind of playing, almost as a one player, coordinating all this like an orchestra. So that was interesting. I appreciate that. And we should make this system automated, much more systematic, in such a way that we have data collection, sharing, processing, and applying AI, deep learning or whatever these technologies, and then we churn out all these predictions, R values or future R values, and some social distancing parameters, and this is automated. And I was surprised actually we didn't have that system because it happened to be my field, and so I would expect that such a prestigious institute in Korea should have that kind of system, or at least they should have supported the scientists in such so that they can show those. Anyway, my last remark, the Korean lesson, all these is and the responsibility of the government. When the disaster struck, the most important player, whether we like it or not, is the government. And government needs to be brave. People gave power to the government, actually for this kind of occasion. Of course, power is dangerous. It's always dangerous. When you abuse the power, you can actually sacrifice democracy or everybody's rights, human rights, whatever. But at the end of the day, power, in my opinion, whether it is expressed as a scientific power or money power or financial power or whatever power, I think that's what the public wants. So I hope that the government will go brave and adamant in keeping the order in such a way that we don't accept nonsense. We don't accept this anti-social behaviors, sabotages. Secondly, the government should be also brave in taking the responsibility for companies. The vaccine factories. They want to give their kind of vaccines, but they are afraid in a way to get the responsibility of side effects. And also the scientists as well. Scientists want to get the data, possibly infringing some privacy, personal, information and so on and so forth. And at this point, government should be brave in that approving those test kits, approving vaccines, and approving data sharing, and they should go ahead, in my opinion. Why? Because they need to use science and technology, because science and technology is the only powerful tool we have. And I hope the whole Korean government, the many ministries of government in the future will be much more brave in embracing science and technologies and actually giving power to the authorities and scientists, and eventually making this science innovating, science-driven, data-driven system against pandemic. Thank you very much. That's it.
Thank you, Jong-ha Park. I think I like the background he has behind him. That is I think the shining the universe. That's what I actually watched a second ago. I don't see it anymore. You're gonna give us 2 shots? Oh, okay. Oh, that's good. That's better. So I felt like I returned to London. So that's another reason I enjoyed listening to Dr. Jong-ha Park. So I spent a few, I think the moment, some time back in London when I was younger. But anyway, I think we had pretty good, I think the coverage. Starting with this good, I think the coverage of the foundation, medical foundation, clinical foundation, Dr. Kyungnan Park shared with us. And then we moved on to this discussion of the how machine learning, deep learning of the AI can be a good tool of predicting the status of the patients in advance. So that is what Dr. Tae-sung Park shared with us. And then I think our discussant I think has very energetically shared with us sort of this large sort of context. Sort of, this is the human disaster, and there are roles the scientists have to play, and also the mission that he actually recommended to the government. So we covered a lot of things in a very brief moment. I think Dr. Jong-ha Park has not raised any particular question to the presenters, but let me be very open to both presenters. This is the moment, perhaps I'd like to give to Dr. Park first to comment on comments, if you have any. Also, Dr. Park, if you have any comments on comments, I can come up with my own questions, but at first, I'll make it open. So, Tae-sung, if you have any comments on comments that you heard from Jong-ha, would you like to go first?
So you have no question to me? Okay, I think it's very impressive speech actually, right? I think I'm focusing about some of the issues what I'm dealing with and some of the data. But I think Jong-Hwa Park has some intuition. He is looking at some big pictures, right? So he raised very fundamental issues what we are dealing with right now. Like we are dealing with COVID-19 situation we have never ever experienced before, right? So far, I think our government is doing okay using the 3T. And now we are talking about some precision like kind of things. We like do the same strategy for medicine to like the infectious disease, right? But while working on this kind of new situation, we are still very struggling, right? So what we have to do is that we have to work with together like, in one big system, right? As the Jong-Hwa mentioned, we have to share our ideas and what we learned. So we have to find out what we can do together for the future, for the fight with COVID-19. So I think as a scientist, it's very important to share what I've learned so far and what I have right now. So it can be very useful to other scientists. And especially, I mean, the sharing the data would be very critical issue, right? And I've worked with the KDCA, right, people, but they are very reluctant to share the data set, although I'm very lucky to have a chance to working with them and have a chance looking at the data set. But I got only the early, like the May, and I wish I'd like to look at some other more recent data set because it's changing a lot. It's changing very rapidly. If I had more data set, I would be able to get some more predicted results. That's what I want. And also to work with the government people and the scientists would be very important. So the fundamental thing we have to deal with the communication, right? If we understand the other parties, then they understand our party too, right? So while working with together and while communicating together, I think we need to find out something what we can do together. But so far, I think the scientists and our government and have been doing okay right now, but we can do better. That's what I think.
Okay, thank you, Taesang. Perhaps before I move on to Kyungnan, let me just ask one question because I think you kind of suggested it. I had actually quite a few questions, but I'll just pose one. That is, assuming this model and methodology you proposed is just going to be rigorously working. And you certainly proposed to the government, we need quality data so we can have, the better AI tools based on this quality data. That is the one suggestion. But what is the thing that you like to do, assuming everything is just working pretty well? What are the next steps that you wish to take? So this tool, this nomogram you developed can be useful.
Okay, actually, as a scientist, as a statistician, most people are very interested in publishing the result, right? And using their results, they are very interested getting some grant for their study. But when I first looking at this data set, I was aware of that I'm not able to publish any results, right? But I just want my analysis results would be informative to government people to make good decision to fight with COVID-19. That's all I wanted. But still, I think it was not easy to work with them, right? So that's why I could not get any further results since May. But as you said, if we get more data set, then I'm pretty sure that we can get more better predicted results. And my hope is that our prediction results can be freely used for any infectious disease clinicians, right? To make some predictions. And I know that some patient in ICU, they need not to be there because if that ICU is vacant to some other who actually need ICU very urgently, they can take that space, right? So we can use the kind of efficient space ICU allocation kind of things, and that kind of allocation actually reduce a lot of medical costs. So if we look at together and if we use this kind of allocation of programs wisely, then we can do a lot of things, right? That's what I want. Right?
Okay. I think that you are actually suggesting a lot to the clinical people, medical community, and also perhaps a lot of people listening to this section online. If you're out there, if you're medical doctors, medical practitioners, you just saw the tool here, right at this moment. You can speak to Taesung after this section, and then please stay in touch. And so we can actually work together. And actually, I really like this term that Jonghwa used. Perhaps I was playing a role of, orchestrating, a lot of different players. Actually, I used to be conducting boys choir when I was young. So I love to do team play. And that was, something I enjoyed a lot. Of course, Korea has a lot of talented, scholars, researchers, and then people with, quite a lot of different, I think, the wisdom. So it's been fun. It has been fun, this year to be working together. So I'll just stop there, but let me turn to Gyeongnan. So I think I gave you some time to think about comments about the comments that Jonghwa has made. So do you have any comments to share?
Actually, I'm a clinician and I'm not so familiar with this kind of modeling and especially the using the AI. Yes, and actually I learned a lot during this COVID pandemic condition. For this modeling and AI. Yes, and. So I think Dr. Taesung Park and Jonghwa Park showed very informative data and very good comments to prepare and respond to the next pandemic. As you know, at the beginning of this year, we didn't know anything about the COVID-19. So we responded to the COVID-19 based on the knowledge got from the other disease and from the past. But during the first 1 year, we have many information about the COVID-19. So I think we can change our response more precisely based on this very informative data and knowledge. Yes, and like the patient allocation or some preparedness for the medical facility like that. Yes, I think this collaboration is very good to overcome this condition.
Okay, let me ask you just one question. As I was listening to your presentation earlier, and also other parts that I heard from Taesung and then Jonghwa, you're a clinician, clinical medical doctor, and you actually covered this foundation and foundational characteristics of this COVID-19 pandemic. And you talked about these clinical complications or the side effect, as Taesung noted. And then among those the clinical complications, you noted sort of this psychological effect of the COVID-19, such as depression, anxiety, and other mental, I think, the pressure. So my question to you here is that how, what would you suggest? What would you suggest to cope with this kind of, mental, I think, the illness, the depression, anxiety, as the, the symptom of this COVID-19, and then what kind of preparations we gotta do, to deal with it?
It's a very difficult question. Actually, I don't know the answer. Maybe you asked me because you don't know the answer also. I think the psychological problems came from both because of disease itself or from because of the other secondary condition like the social stigmata like that. I think the second cause can be more responsible for the psychological depression like that. So at the beginning, we gave the bad stigmata to the infected person. So as you know, we can be infected anytime, at any place, even we can't notice if it is dangerous area or not. So I think we have to change our thought. This is a kind of disease, just a disease, and they are just patients, and we have to accept the patients as a victim, not. So yes, they can be more helpful to coming out of the patients to the society. Yes, and they can be I was thinking. So this changing, they can. I think more patients can be easily tested if they have the infection or not. So maybe we change the word is confirmed cases instead of confirmed cases. We call them just a patient or infected person. Maybe we have to change our words first.
Okay. Just like you said, this is not an easy question to answer, but I wanted to learn from your experience as a clinical the specialist. Part of the reason I asked that question, I'm aware of this recent study done back in the States. When they followed up, a lot of these COVID-19 patients who are recovered, and they did a follow-up survey. They actually found 1/3 of those recovered people actually experienced some kind of mental illness, depression and anxiety, things like that. So if that was the case in the States, it may, be also true here in Korea. We have a lot of people recovered, but some of them actually have complained about some of this. I think the remaining the mental, the pressure and then mental sort of the characteristics. So we got to be prepared better for dealing with that kind of the symptoms, because depression and anxiety is very highly correlated with suicidal attempts in many countries. And that is one thing I'm very concerned about. And we got to be better prepared. If not, we may have, the more episodes of the suicidals in the near future. And we got to have some preventive actions here. So that's the sort of, there's something behind. Would you like to add a few words? Okay, yeah, please.
Yes, I think even other people, not except the person, can have the mental problem also, like the depression or anxiety. Yes, so maybe the government should handle this problem also.
Okay. Before, we are almost close to, the time to wrap up. But before I do that, I'd like to give 1 minute to each person, including discussant, the Jonghwa. You heard some of these comments and responses to some of the answers in the limited time. I'd like to give 1 minute to each person to wrap up your thoughts, and perhaps a few things that you'd like to reiterate, or some actions, or some the other suggestions that you have for this online community, listening to us, or the people out there, the important stakeholders that we need to work together. So let me start with perhaps the Jonghwa. You have 1 minute.
Thank you. So my last comment is we should automate the experience of Korea in coping with this pandemic in terms of automating the data processing, sharing the patient's data, the 3T, and also how we can predict the outcomes of this, the average and so on. So we should automate all this as infrastructure. Thank you.
Okay. Kyungnan, you have 1 minute.
Yeah, I think we have to change it differently from the past, and we have to modify our strategy based on the current status, and very rapid action is needed. And the very close collaboration between the scientists and the government persons are very essential to overcome this disaster.
Okay, thank you. Taesung, you have 1 minute.
Yeah, I think the more we can work together, the more we can achieve to fight with COVID-19.
Okay, that's very short and succinct. Actually, let me wrap up today's section. I have a little over 1 minute. I think this final sort of concluding comments I have heard from these the speakers and discussants reminds me of this first meeting, international online meeting that I had back in April with highly, I think, the influential the experts around the world. And we got together online, about 70 people, in response to this call by CIFA, Canadian Institute for Advanced Study. This is the institute actually mandated by the Prime Minister of the Canadian government. Actually, they put together a lot of these experts around the world, about 70 people, and they talked about what should we do in the wake of this COVID-19 pandemic. This was back in April. They said, as I recall, the 3 things. First, we got to have collaboration. And that's what we heard today. Second, we need data, quality data, so we can work together, share together, and then help fight this pandemic with worldwide team play. It's not limited just to one country, worldwide team play. The last thing is more team and then coordination between governmental, non-governmental, and then other players all together. More collaboration in the near future. And that's actually what you heard from all of us this afternoon. So let's work together with those kind of spirits so we can continue to flatten this pandemic in the coming month. And just like all the speakers shared together with you, we are ready to work together with any of you listening to this section, and then we'll take next steps together in Team Spirit and with this Team Korea. And thank you, everyone.
Thank you very much.
Okay, bye-bye.
Bye.